Hi, my name is Jennifer Wilson, and I am part of the group presenting endocarditis. Today I'm going to be talking about the pathophysiology of it. Infective endocarditis is an infection of the endocardial layer, which is the innermost part of the heart, and the valves. It includes the valves, and it's normally caused by bacterial infection, staph, strep infection. It can also be caused by viral or fungi, but it's a little bit more rare. The people that are susceptible to infective endocarditis usually have previous damage on their valves or on the endothelial surfaces. So people with heart conditions, pacemakers, valvular disease, IV drug users, people who've had endocarditis in the past. And what happens is, because there is scar tissue and because there has been damage to the endothelial surfaces, microbes can get in and kind of get stuck on that damage, and then it causes further damage. The inflammation process starts. Fibrin, leukocytes are recruited, platelets come, and so it kind of creates this colony, and they actually call that colony vegetation. And in about 50% of cases, that vegetation actually can break off and cause embolisms. So pulmonary embolism is a major consequence that happens because of those breaking off of the emboli. And there's a couple different types of endocarditis. Rheumatoid heart disease is a cause of endocarditis in about 20% of the cases. It was actually quite greater before the advent of antibiotics, but because rheumatoid heart disease is caused from group A streptococcal pharyngitis, so basically, your standard strep infection that ends up moving to the heart, because we end up treating strep infections a lot with antibiotics, it doesn't create those consequences. But what happens with rheumatoid heart disease is that it is chronic on all the layers of the heart, and it's chronic inflammation that takes place, where infective is a bit more of an acute disease. With rheumatoid heart disease, it creates thick lesions on the valves, and actually fibrosis of the papillary muscles, infusion of the chordae tendineae. So it basically kind of calcifies and creates stenosis, which is a very severe complication. So that is the
Clinical manifestations of endocarditis can be nonspecific and involve multiple organ systems. Low-grade fever may occur in 90% of patients. Other nonspecific manifestations include chills, weakness, fatigue, anorexia, malaise. In subacute forms of endocarditis, manifestations are back pain, abdominal discomfort, headache, and clubbing of the fingers. Vascular manifestations of endocarditis may include splinter hemorrhages, which are black longitudinal streaks in the nail beds. Petechia can occur in conjunctiva, lips, buccal mucosa on the ankles, feet, and antecubital and popliteal areas. Osler's nodes are painful red or purple lesions that are on the fingertips or toes. Janeway's lesions are flat, painless red spots that appear on the palms or soles of the feet. Roth spots are hemorrhagic retinal lesions that can be found through examination. Onset of new or changing murmur happens with most patients with endocarditis. Aortic and mitral valves are often affected. On the left picture is an Osler node on the thumb. In the middle picture is a Janeway lesion, and on the right picture is a splinter hemorrhage. Blood cultures need to be taken. 2 blood cultures will be drawn 30 minutes apart from 2 different sites. In 90% of patients, the cultures will come back positive. In negative cultures, they should be kept for 3 weeks to see if it may be a slow-growing organism. In acute endocarditis, leukocytosis can occur. ESR and CRP levels may be elevated. To diagnose, at least 2 of the following criteria must occur. positive blood cultures, new or changed murmur, or an intracardiac mass or vegetation noted from an echocardiogram. Echocardiograms are done to detect any vegetations that have occurred on any of the heart valves. Chest x-ray can be done to detect cardiomegaly or an enlarged heart, and an ECG may show first or second degree AV block.
Drug therapy for endocarditis involves the accurate identification of the infective organism and is the essential element to successful treatment. Long-term treatment is necessary to kill the bacteria that have been dormant within the valvular vegetation and generally takes weeks. Initial treatment begins with IV antibiotic therapy based on blood culture results. The effectiveness of therapy is assessed with subsequent blood cultures, and the most common drugs used in the initial treatment of endocarditis are vancomycin, gentamicin, Ancef, rifampin, ampicillin, cefazolin, and metronidazole. Fever can be treated with aspirin, acetaminophen, ibuprofen, along with fluids and rest. Antibiotic therapy is usually 4 to 6 weeks, and in the cases of a fungal infection and prosthetic endocarditis, early valve replacement followed by a prolonged 6 weeks or more antibiotic therapy is recommended. The prevention of endocarditis involves the prophylactic treatment for those at high risk for endocarditis. It helps reduce the incidence and recurrence of the disease. Those high-risk groups are people that have a prosthetic heart valve or prosthetic material used to repair a heart valve, a previous history of endocarditis, congenital heart disease, and cardiac transplantation recipients who develop heart valve disease. When the target groups that I mentioned on the previous slide have the following conditions or procedures, they need prophylactic antibiotics. And these procedures are a dental manipulation involving gums or roots of teeth, puncture of the oral mucosa, extractions or implants, and prophylactic teeth cleaning with expected bleeding. And the reason for this is because those certain procedures might allow bacteria from the mouth to enter the bloodstream. Other procedures are respiratory tract incisions, for example, a biopsy, a tonsillectomy, and a adenoidectomy. Gastrointestinal and genitourinary conditions such as wound infections and urinary tract infections. Nursing care involves collecting the blood cultures prior to drug therapy, fever management, monitoring the antibiotic serum levels and the white blood cell count to make sure that the antibiotic is at therapeutic level, and the WBC count to make sure that it's being effective. Monitoring the kidney function because antibiotics can be nephrotoxic, monitor vital signs, monitor for superinfection, monitor for severe diarrhea, and monitor the IV site for signs and symptoms of tissue irritation, severe pain, and extravasation.
Hi, Amanda here. I'm going to be discussing nursing diagnoses for a patient with endocarditis. First, we have activity intolerance related to imbalance between oxygen supply and demand, decreased cardiac output related to cardiac disorder, and fatigue related to physiological condition. As evidenced by could include objective data such as decreased oxygen saturation, increased respiratory effort, dyspnea on exertion, changes in heart rate or blood pressure, changes in EKG, fever, pallor, or cyanosis. Subjective data could include things such as the patient stating that they feel lightheaded, dizzy, weak, tired, or are having trouble breathing. Anxiety, fear, and death anxiety are other possible nursing diagnoses. These can be related to a change in physical condition, serious threat to well-being, or potential danger of condition. For these diagnoses, as evidenced by, can include objective data such as fidgeting or other restless behavior, rapid speech, or diaphoresis. Subjective data could include statements made by the patient, including "I'm scared," "What will happen to my family if I die?" and "What is happening to me? Why is this happening to me?" Risk 4 are diagnoses that are often not used in our care plans, so I won't go into them in much detail, but it gives you an idea of other possible nursing diagnoses you could use.
Endocarditis is often characterized by the formation of vegetations, which consists of fibrin, loculocytes, platelets, and microbes that form on the heart valve surface and endocardium. These vegetations can give rise to many of the complications that occur with endocarditis. For example, pulmonary embolism. These often occur due to an infected vegetation that travels through the lungs and blocks a lung artery. Signs and symptoms of a pulmonary embolism include shortness of breath, chest pain, and cough. Another complication is stroke, or arterial embolization, which also can occur due to a vegetation breaking off and blocking an artery. This can be identified by sudden weakness on one side of the face, one side of the arm, leg, confusion, dizziness, and sudden headache. This is the second most frequent complication that occurs with endocarditis. The first most frequent complication of endocarditis is heart problems, especially congestive heart failure. And it can develop after months of untreated disease, or it can also develop after treatment and the patient seems well. Other heart problems that can occur with endocarditis is myocardial infarction, heart murmur, heart valve disease, and these complications can be identified by EKG, ECG, and cardiac auscultation. Other complications include seizures, paralysis, and abscesses that develop on the heart, brain, lungs, and other organs. Kidney damage, glomerulonephritis, acute renal failure, which can be identified by urine analysis. Also, other complications include enlarged spleen, mesenteric splenic abscesses, or infarctions. All of these complications can be prevented largely by early identification of endocarditis and treatment. The further endocarditis is allowed to progress, the more likely these complications will occur and the patient will suffer more severe symptoms. Well, that's all for the complications for endocarditis for today. Thank you so much.